Everyone, welcome to this session. Thanks very much for joining us. My name's Jill Lowe. I'm a haematology consultant who specialises in thrombosis and bleeding disorders, and I'm based in Birmingham, and I'm delighted to have colleagues joining me on the panel for this session who we'll introduce in a second. And I hope you've been enjoying the rest of the conference so far. So the title of the session is Getting It Right, Case Studies in Prevention and Early Diagnosis of VTE. And we really want this to be about learning from lived experiences. And I'm very grateful to Hannah and Andrew who are here to give us their lived experiences. And we hope that what Hannah and Andrew share with us will prompt lots of discussion, both with the attendees here and with the panel that we've got. So please do submit questions. It would be great to have your participation. We want this to be informal and to involve lots of discussion. So first of all, I'm just going to ask the panel to briefly introduce themselves and then we'll get started. So Hannah, if I could ask you to introduce yourself first, please.
Yeah, of course. Hi everybody, my name's Hannah. I'm 22 years old. I've previously suffered a deep vein thrombosis, which is why I'm here today to tell you all about my story and how I think things could have been done differently so that we can all learn and make a change for the future.
Thanks very much, Hannah. That's great. We're delighted to have you. And Andrew, if I could ask you to introduce yourself next, please.
Good afternoon all. My name's Andrew Morris. Again, like Hannah, I'm a previous patient for someone who suffered a DVT and a submassive pulmonary embolism, which was saddled. I'm here to sort of like share my story and hopefully make things better for the future for future patients.
Excellent, thanks very much. Matt, if I could ask you to introduce yourself, please.
Hi, I'm Matt Fay. I'm a GP based in Bradford. I'm a GPSI in cardiology and vascular disease. I'm here to give a view from general practice, frequently the entry point to the NHS, and hope to learn from Hannah and Andrew's experience and share some of my own experience of seeing VT present in a general practice setting.
Thanks very much. And then Dan, if you could introduce yourself, please. Thank you.
Good afternoon, everyone, and thanks for the invite to be here. So I'm Dan. I'm a consultant in emergency medicine and intensive care, working in the northwest of England. And I've also got a research interest in thrombosis. I've been an active researcher for around the last 10 or 15 years. I've also participated in NICE guidance on the topic of preventing and treating venous thromboembolic disease, and I chair the thrombosis committee at our local hospital, which is a VTE exemplar centre. So I'm here to again share experience and listen to the stories, because we know that no matter how much work we put into this, we still don't get it right sometimes, and it's very key that we continue to develop and get better.
Excellent, thanks very much. So hopefully we've got a panel that represents lots of different perspectives, lots of different parts of medical teams that would look after patients with thrombosis, and it'll be interesting to get different perspectives on that when we talk through Hannah and Andrew's experiences. And I'm particularly interested to know what Matt and Dan would want from haematologists in terms of how we can make your lives easier, and hopefully vice versa, so we can pick up on that in the discussion. We're a little bit ahead of the planned time to start going through stories, but I'm going to start doing that if that's okay, to give us plenty of time to discuss things. So Hannah, first I'd like you to just tell us your story, and we're going to let you do that without any interruptions. I'll then come in at the end and I'll start with some questions, and we'll hopefully get some through from delegates. So please go ahead when you're ready. Thanks very much.
Wonderful, thank you, Jill. Yeah, it's finding somewhere to start, really. First of all, I think I'll say that I think this panel is a really useful example of the path that a patient goes through. I know for me, I went through my GP, I then went to A&E, and then I finally saw a haematologist. So I think it's going to be really interesting to have the perspective from all areas of primary and secondary care. My DVT journey really started, I was 18 years old and I developed some swelling in my left knee. It was purely swelling. There was no redness. I hadn't had an injury. It was just a swollen knee, around the knee. As a child, I'd been under investigations for having clicky bones, so I'd constantly been under an arthritis clinic. So the first thing that my GP said to me was, well, it must be this arthritis that you've had investigations for as a child. And that was the path we went down. I was prescribed some anti-inflammatories. I had some steroids at some point as well. And the first path that we went down was arthritis. And this swelling in my leg just got worse and worse over the period of about 2 weeks. I was waiting for a referral to come back, an appointment to come back from the arthritis clinic for the referral to there. And this swelling was still localized to my knee, and it was just getting worse. It wasn't getting better. She'd given me all these tablets to take, and her only advice really was to rest, which I couldn't do. I had, I was working. It can be really hard to rest when someone tells you to, when you've got lots of things going on in your life. So I was a bit frustrated. I kind of felt like these symptoms aren't getting better. All these tablets you're giving me, I'm rubbish at swallowing tablets anyway, and they're not working. So yeah, I was frustrated. Over 2 weeks, this had got worse. I went back to the GP and saw a different one this time at the practice, and they kind of had the same opinion. They weren't concerned about VTE. It wasn't mentioned. At this point, I hadn't really considered it. It was kind of, I knew blood clots were a thing, but I was very much of the opinion that they were in old people or people that had risk factors. So I was very much, it won't be that. I tried to not think about it. It won't be that, because I'd never been led to believe that it could be at that point. So anyway, I went back to the GP. They were still very much under the impression that because it was localized to my knee, it wouldn't be that. It didn't cross their mind. I did have some blood tests, and from what I can remember, I think they came back as normal. So they kind of just got ignored, shoved under the carpet a little bit. I then went to an A&E unit where I sat waiting for a while. I was in excruciating pain, just with this knee swelling, still with just this knee swelling. I saw a lady in A&E who was confused. She was very much, well, you've been on all these tablets, you've been to your GP, you're waiting for this referral letter to come back, nothing's getting better. Let's have a look at what this is. And I remember her looking at my leg and just saying, I don't know, I'm quite confused. I need to go and speak to colleagues about this. And this was a nurse in the triage, I believe. I then had some blood tests while I was there, and I had a raised D dimer, which is what triggered these DVT concerns. And I remember being sat in A&E researching it myself. What does this raised D dimer mean? What does this mean while I'm sat waiting? And first things that come up is to do with clotting and blood clots and all these things. So as I'm sat waiting, I'm like, God, this could be a blood clot, but how? I've not been on a long flight. I've not been on the pill. I'm not old. I'm relatively healthy. All the things that come up on Google. So anyway, they told me to come back the following day for an ultrasound scan. I went back for the ultrasound scan, and it was nothing. There was nothing on there, nothing detected. I then went back a week later for an ultrasound scan, nothing detected. So at this point, I think this was about the 2 week point. So I was still in pain. At this point, it was spreading up into the top of my leg, down into my calf, this swelling. And it was getting hot to the touch. It wasn't necessarily red, but it was getting hot and really swollen. Another week passed by, and I was at college in a different local area. And I went to a different A&E. So I wasn't in the area where I lived. I was somewhere else. So I went to a different A&E unit, and I walked in, and my toes were like stuck together. They were so swollen. My whole leg was like a balloon. I couldn't fit my jeans on even at this point. Like, I had to put on jogging bottoms, which was totally alien for me. I was like, I can't go out wearing those. So I walked into A&E crying my eyes out, because at this point I was in so much pain. I'd done my research while I was sat in A&E the previous week. I knew I had this raised D dimer, but I was confused at the fact that my ultrasound scan had nothing on it. I went into this A&E unit. Within minutes, they had me on an ECG machine. I'd had bloods. I was on the system to go down for an ultrasound as soon as possible. So that must have been at about 10 o'clock at night. They then couldn't get me into ultrasound. They gave me an injection, I think it was heparin, told me to come back at 7 o'clock the following morning, where I was straight into ultrasound. And yeah, it was a huge DVT in my leg, all the way up into my groin, into my pelvis, my leg. So yeah, that was kind of the point I got diagnosed. it had taken me 3 weeks to get to this point, and I'd gone through my GP obviously twice and 2 different A&E units before I finally had the answer that I needed. I felt weak, I was in pain, it was uncomfortable, and anticoagulants don't fix the problem immediately. You know, this swelling took a long time to come back down. I went to see a haematologist. Thankfully, they got me in quite quickly. So it must have been about a week after I'd been seen in A&E, I was seeing the haematologist in clinic, which I'm really grateful for. You know, he was really helpful. He explained it to me, how blood clots happen. And whilst they weren't sure why I'd had one yet, he was really good at explaining to me why it might have happened and how they happen. And whilst it's rare in young people, you know, it still can happen. And he was a really good advocate for how I felt as well. When the swelling wasn't going down in the coming weeks, you know, he was there at the end of the phone, and he was explaining to me, you know, there was this thing called post-thrombotic syndrome, which can develop, and the swelling, you know, might never go down fully because of the extent that it had got to. So yeah, the 3 elements of care really that I went through, I feel like the best experience for me was seeing the haematologist. He had a really thorough understanding of what I was going through and how to fix it, really. So yeah, I had a CT scan and an MRI scan after my diagnosis. I've been on Finspirine injections for about a month. The swelling was starting to go down, but not entirely. And obviously they wanted an answer as to why I'd had this DVT. They found that because I was born at 26 weeks gestation, they believe that I've got a blood vessel problem with one of the main vessels running from my heart down to my legs, which means that the way that they described it to me was that it doesn't attach the way that normal people's would. So it's like its own system. My vessels don't join up in the way that they should. They've sort of broken off into their own little small vessels and then join back together again, which makes the blood flow to and from my legs quite weak. It's not as strong as it should be. So that's kind of why they believe I had this blood clot in my leg. So as a result, I'm on anticoagulants now for life. They don't believe it's something they can fix, and obviously being on anticoagulants just reduces the risk of me having another blood clot, which helps. So yeah, that was kind of the point I was up to with my diagnosis. That's kind of how they discovered why they think I had the DVT, and then the anticoagulants for life are kind of the measure to hopefully stop me from having another one.
Thank you very much. There's absolutely loads to think about there, isn't there? And we're grateful to you for sharing that with us. I think the themes that come across to me when you're talking are about how much you needed to persevere to get to that diagnosis. And obviously I'm the person who would usually see you at the end of that process, the haematologist, and often, you know, by that point the hard work has been done and that the diagnosis has been made. So if you had to pick one thing about that process that you think could have been done differently, what would be the one thing that you would identify that could have been changed that would have made things easier for you, do you think?
I think being listened to, and I think my symptoms being monitored a bit more closely. And I think it's more the sense of the clinicians and the doctors thinking VTE. They weren't thinking that, they were thinking other things. So I think maybe if they'd have thought that first, the whole arthritis route I went down might not have happened. You know, they might have thought that sooner. I know now if I have any swelling in my legs, because it's already happened once before, they say straight away, go, sorry, I've just read this comment, not detected in the first. No, exactly, it wasn't detected in the first ultrasound. And I've always wondered why. The swelling was definitely there, and there was a good week-long period between me having those. I'd had 3 ultrasounds in the space of 2 weeks. So yeah, I do wonder the same thing, why it wasn't detected. Sorry, I've lost my train of thought there.
That's okay. Yeah, I think that comment that's been submitted is helpful, and I'm sure lots of us thought the same thing as we were listening. I mean, from my perspective, we know that if clots are right in what we call the proximal veins, which are the ones in the pelvis at the top of the leg, sometimes we don't see positive ultrasounds. So sometimes that's one reason, because we can't see how high up the clot is on a scan of the thigh. And then we do know sometimes that initial scans are negative, and then we find things at a later stage. But That's why the important thing for us as clinicians is to treat symptoms and to assess symptoms, and not to be falsely reassured by scans that are negative. And the algorithms that we all have for managing acute DVT would say that if there's a clinical suspicion, we rescan or we review patients and we monitor that. The other thing that I was going to ask you, Hannah, is we sort of often talk about the immediate treatment. You've mentioned that the haematologist talked to you about post-thrombotic syndrome. But one thing, especially in young women, that we perhaps don't talk about so much is the implications on contraception, pregnancy and relationships when you're on anticoagulation as a young woman. What was your perspective about that?
Yeah, so thinking about that element, after my diagnosis, after the haematologist at the trust had found what they think was the cause of the DVT, I was referred to a different hospital where I saw a different haematologist, and she specifically asked a lot of questions about contraception. The male haematologist that I'd seen at the previous hospital, I don't really recall him asking me questions about that, to be honest, be it because maybe he didn't think of it or because I was in the initial stages of treatment. I don't recall him asking me that there. But yeah, in my follow-up care that I had at the next hospital that I went to, I had phone calls with her every 6 months through the pandemic, because at this point we were hitting COVID, so I wasn't going in. She'd ring me every 6 months, ask how I was getting on with my medication, ask about my swelling and pain, sort of in this recovery journey, because the swelling took a long time to come down for me, and I'm not talking 2 or 3 weeks. It took a good 12 months for my leg to feel normal again after what happened. And even now, I have a varicose vein running through my leg, which has been made a lot worse since I've had the blood clot. The varicose vein was already there, but it's a lot worse than it was, and I can't have it removed, etc., because of other complications. So yeah, I had a lot of follow-up about that. She specifically asked a lot of questions about contraception. She asked if I was planning to have a baby, which I wasn't at the time. And yeah, they definitely made me aware that if I ever wanted to have a child, to contact them straight away, even though I've been discharged from them now. We're talking 3.5 years since my diagnosis. I have been discharged, but I know that they're there if I do plan to have a baby, and to go back to them, to obviously keep me safe and future potential children safe. So yeah, she very much spoke about that. You mentioned relationships, Jill. I think my partner, Sky, she's been a real good support to me through all of my diagnosis. And since, it's something that we've grown to live with since having my VTE. I can't walk the distances I used to be able to walk. I can't always stand on my feet for as long as other people can. And I always have these thoughts about, can I go on roller coasters? Am I going to hit my head? And I don't want to go on that walk in case I fall over and get a bruise, or if I cut myself, I'm going to bleed lots. And I think in that sense, there's been lifestyle changes that we've made as a couple. So yeah, I think it is something that definitely it has an impact on, not necessarily a negative impact, but definitely an impact. And I'm sure Andrew can probably relate to relationships and lifestyle changes. I'm sure he'll go on to talk about that.
Yeah, and I guess that's why perhaps over COVID, when we couldn't always have next of kin or people to support the individual in consultations, perhaps we lost a bit of that longer term aspect of care that you're saying about, not just the affected individual needing to cope, but those around them as well.
Absolutely.
There's one other comment from Dan, so we'll do that and then we'll move on to Andrew's story, if that's okay. So Dan's question was, did they scan your whole leg during the first ultrasound scan, including below the knee, or did they just scan the knee and above?
I think it was the knee and above. Now I look back. I remember at the first time, because I remember it being uncomfortable, pushing the scanner right up into my groin, the probe, that's the word, into my groin. I remember her doing that, but my recollection of that scan was that it was a bit blasé. I might just be thinking that now because I look back and I'm frustrated at the situation, but I remember the third ultrasound scan that I had being much more thorough, where she did find it. So yeah, my recollection isn't that because I'm sure she scanned in my groin and then because she didn't see anything, she stopped. That's kind of what I'm remembering. I don't remember it being as thorough as the one where I finally was diagnosed, which for me is what is so frustrating about the whole thing.
Dan, did you want to make a comment on whole leg versus above knee scanning, or just talk a bit about why you asked that question?
I'm happy to save that for my slot, if you like.
Okay, that's fine.
I'd ask while Hannah's story was fresh in everyone's mind, and then we talk a bit about diagnostics.
Great, we can come back to that later. What I would say is my trust at the moment don't do below knee scanning. We do knee and above, and obviously that is something where perhaps sometimes we do miss things that then propagate and we find at a later stage, but we can pick that up again later. Okay, I haven't seen any of the chats or comments come through. Does anyone else on the panel have any points or questions to ask Hannah before we move on? Okay, thanks very much, Hannah. That's been great. So we're about the timing in the session to move on to Andrew. So Andrew, we'll do something similar with you, if that's okay. We'll ask you to tell us your story and then we'll pick up on questions from there. So over to you, and thanks very much for your contribution.
No, thank you, Jill. Firstly, apologies for my voice. I think just like Matt, I'm recovering from COVID. So it's not great, so apologies there. My journey started coming up to 5 years ago. I was working and I got hit by a car. It was pedestrian versus motor vehicle, and I got rushed to Pembury Hospital under heavy medivac, and they suspected a broken pelvis and spleen issues, which was quickly negated. I then was confused, unfortunately, with another Morris in A&E, and there was a James Morris and I'm Andrew James Morris, and they actually x-rayed my arms rather than my legs and discharged me on painkillers, which was really sort of like really confusing, really. And I spoke to the actual clinician team there and said, why are you x-raying my arms? It's my legs which are got hit and the impact on the actual waist side of things. But they said, oh no, you're absolutely fine, go home, take these painkillers and you'll be fine. Weeks, 10 days went by. I represented at a different A&E down in QE, and again, pain wasn't going away. Leg was starting to get swollen and hot to touch, but again, I was just told to carry on taking the pain medication. It's soft tissue damage. No one sort of was thinking sort of blood clots and that. At the time, I was a very fit person, did lots of sports, lots of stupid sports as well. So used to like throwing myself off cliffs for a living and doing gorge walking and stuff like that. Time went on though from this, it must have been between Christmas and New Year. I started feeling strange. I can't even sort of like give you the actual feeling it was. It just felt like something was going on with my body, which I couldn't actually explain at the time. So I spoke to the 111 service, and they actually just advised again, carry on taking the pain medication, speak to your GP in the new year, which I did. So on the 8th of January, I contacted my GP, and they did a telephone consultation, looked through my records, no previous for sort of like medical needs. So I was literally, the only time I saw my GP at the time was for like traveling abroad. And they said, oh no, just carry on taking pain medication. It's probably just swelling from the actual impact and bruising. Carried on going. Spoke to them again in February. Again, telephone consultation. Leg at this point, I was finding it really hard to walk on it, and I was going through a tube of Voltarol gel every 2 days, and it was just basically just getting worse and worse to walk. The pain was just excruciating. My chest was starting to get tight, and I just was feeling like just walking just a normal sort of amount of sort of walk between my desk and the printer, or going up a flight of stairs, which is getting really hard to do. And I was just like, this is wrong. And I spoke to again, my medical provider, and they just were like, oh, if it gets any worse, call us back. And it was like, well, that's helpful, great, thank you. So I consulted a pharmacist, and the pharmacist gave me a stronger painkiller. They gave me cocodamol. Again, it just wasn't feeling straight. But then on the 8th of March, I actually collapsed. I collapsed at work. I'd just done one flight of stairs, the flight of stairs that I'd done all the time. I walked into the office. I was grey. I was sweating. I'd actually presented like I'd actually was having a heart attack. And at the time, I was fit and healthy. I wasn't the size I am today. And my colleagues called an ambulance to be flabbergasted that it was a 4-hour ETA from CCAM because they were surge red. It's like, right, okay. My GP was across the road. Got taken to my GP by my colleagues. And my GP turned around and said, I'd had a panic attack. And I was like, but my leg is swollen. Like Hannah, I couldn't get jeans on. I couldn't wear normal sort of like trousers, which I'd wear for sort of like day-to-day sort of work-wise. I couldn't get my shoe on properly. And my chest felt like I had a sandbag just crushing me. And I just couldn't walk at all. And they were just like, yeah, you've had a panic attack. Here, take some beta blockers. Fantastic. 2 days later, I presented at a minor injuries unit in Whitstable. And I owe my life to a lady called Heidi, who I was at the counter. She was stood behind the receptionist, and she said, before you sit down, Miss Morris, go into room 1. I went into room 1. She did a D-dimer straight away. She stabbed me with Clexane, and the D-dimer came back positive. I got rushed by ambulance to QEQM, and I spent just over 4 weeks in intensive care, HDU, and on ward. It was literally unbelievable, to the point where the doctor in the actual critical decision unit at the time was like, we need to speak to your family, and you're going to need to actually speak to them. My wife came down, my little girl, to accident and emergency in the ICU team, and she got told by Dr. Lowe that it's more than likely I wasn't going to survive the night. And that there was just literally like reality. It was like, what? Sort of thing. And that's when it just all came out that I'd actually had 21 blood clots. I had a massive DVT, a massive pulmonary embolism, which was submassive, saddled across both lungs and pushed up against the actual. It was also restricting the heart movement as well, the actual circulation and the actual oxygen getting to the actual body, which was causing then the crushing feeling and the constant fatigue. Yeah, it was really scary. I got put on a drip. I wouldn't sleep because I was a fear of not waking up. Yeah, it was hard. Sorry. Sorry.
That's okay. I think, feeling emotional about it is something that I see when I see patients, and it's a completely normal reaction. Matt just put a comment saying that when you had the high heart rate, did anyone say that they thought you were having a panic attack, or that these were sort of emotional symptoms rather than them being related to the PE? And I think that's quite a common thing that we hear from patients, isn't it? That people say, oh, I was told that I was having an anxiety attack, and that was what was causing all the changes and observations that were seen.
Absolutely. I mean, my doctor, my GP, Dr. Pullen, and she didn't examine the leg, even though I told her about it being swollen and being hot to touch. She just assumed. She goes, what do you do for a living? I work for the police. Oh, that's quite stressful, isn't it? Well, it can be, but I don't find it stressful. And then she's like, oh, okay. Well, I think you've had a panic attack. Did the heart rate, did the blood pressure sort of thing? And I did have an elevated heart rate, and that's why she believes I had an actual panic attack. However, like Hannah, if they actually listen and gone, yeah, okay, your leg's swollen, it's hot. You had a blunt force impact 3 months ago. You've had all these symptoms and multiple contacts over hot, swelling, can't walk, pain. I think, and actually just thinking VTE, I think I wouldn't have been in that situation. But I think on the 8th of March, it was too late anyway. I think at that point I was actually heading down to the hospital route. But I think the beta blockers, I got told, slowing the heart rate actually caused more damage than what it actually did to actually support. And that's why on the 10th of March, I was in such a bad way. because I was taking beta blockers, which was slowing the heart rate, which was then preventing the blood from moving quicker around the body. So yeah, I definitely think it had a direct impact, and it as Matt was saying, and that it was due to the higher rate, my heart rate level being elevated, that they thought it was a panic attack rather than a VTE or PE.
Yeah, and we know that in patients who have had PEs or DVT, that there is a certain amount of completely appropriate anxiety after the diagnosis, you know, if you get new symptoms. And I know that Thrombosis UK have done a lot of work with psychology services in terms of how we manage that side of things, as well as doctors, as well as managing your anticoagulation and, you know, the other sorts of physical complications. So I know, Andrew, from talking to you before this session, that you've had various interventions in terms of ongoing problems after your DVT and PE. And I just wondered if you could talk to us a little bit about the longer term complications that you've had before we go to any other questions, if that's okay.
Absolutely, fine, Jill. I mean, my intervention started at East Kent Hospitals Trust, and I got then transferred to Guy's and St Thomas's, where I've been underneath multiple consultants. Some of them you might know, like Dr. Karen Breen, who I know has been on one of the conferences, Professor Black as well, NT. I've been under cardiology, respiratory, vascular, pain management. I've recently had a amazing surgery down at Guy's and St Thomas's. Yes, I spent a month in St Thomas's in March this year, but I had something called the bullfrog procedure done, which is deep vein treatment where it unclogs the vein, because my vein collapsed after the actual DVT, and I've got valve issues where the blood, I've got no venous return from the impact. And this bullfrog treatment basically has reopened that vein, and it's given me some sort of venous return, but it won't ever go back to the way it was until we actually look at sort of like the next level of vein of valve replacement. The hematology side of things, I've had multiple inputs, done different sort of anticoagulants, started on heparin. I've done warfarin, Synthrone, apixaban, and I'm currently on apixaban, and I can't even pronounce the other one which I'm on. It's clobaldrel or something like that.
So, well, we all say it differently as well, I think. A Geordie pronouncing it probably isn't the best way to educate someone on it, but yeah, an antiplatelet agent.
Yes, but that's given to me because unfortunately I had a TIA, a direct result of the actual clot, and I am, I'm sure if Dr. Breen is on or is aware, she actually say, "Not you, Mr. Morris, not again," sort of thing, because my intervention with St Thomas's has been absolutely amazing, and the treatment pathway has been great. I've had multiple psychological input, and I'm under private treatment as well, and I've been diagnosed by Professor Fox as mild PTSD, and it's not from the actual impact of the car, it's actually from the fear of sort of like going in back, having another DVT, but also the hospital stays as well. They're not nice. And to be on a ward where you're surrounded by people who are double, sometimes, and if not triple your age almost, it's not great. I mean, when I first was on a ward, I was next to what I called the deathbed on my left side, where everyone who went into it died, and then the actual right-hand side was basically a gentleman who, during the day, was absolutely fine, but during the night he suffered with dementia, and he thought he was still in the war, but he was also a poo thrower. So he was throwing feces everywhere. And so again, the actual psychological impact of being on the hospital, having that fear of constantly thinking, oh, am I going to get another DVT? Like Hannah, you make life-changing choices because you've got that fear. And I mean, I used to ski a lot. I skied for the army. I was a ski instructor. I've scuba diving, hill walking, mountaineering, and that. I don't do any of that anymore. One, I don't do it because of the pain impact, because I'm under pain management. But also the actual scuba diving side of things, it's a fear because of the lungs and also the pressure. And again, what happens if I come up too quick? You've got all those fears going through your head, and you just stop your life. And it's had a massive, I mean, absolutely massive impact on family life as well. I've got a 6-year-old child. She's absolutely brilliant. And at the time of the accident, she was just 1. So, and it was really scary. I mean, my wife suffered massively on the back of it because she got told in 1 week, and that 3 times to say goodbye to me because I wasn't coming out of that hospital. I can't say otherwise about that impact. So psychologically, I think we need to do more work supporting people who have gone through such a traumatic event where it's just seen, oh, it's just a blood clot, you'll be fine. Well, no, actually, it's more than that.
Can I just add on to that as well, Andrew? Sorry to interrupt. Carry on. Psychological impact, just while we're talking about it, so I don't forget. It's been the exact same for me. And it sounds awful, but it's comforting for me to hear that it's not just me. It's comforting to hear that psychological impact happens to the people as well, because I don't think within healthcare VTE is recognised as having a psychological impact. I've equally had the same fears, the same worries, the same emotions behind it, and it took me a long time to come to terms with what I'd been through, I think, as well. I'd gone from being relatively fit and healthy, and from being born premature, I had a really healthy upbringing. I know I could have had a lot of problems from being born as prematurely as I was. I had very limited hospital visits as a child. So to suddenly then have these health problems that I was having, I ended up having a gynae problem uncovered at the same time as the DVT from the scans that I'd had. So I ended up having surgery for that, hospital stays. And I agree, Andrew, it's the trauma that comes with all of that. And I think from a patient perspective, I really wish GPs, and I'm sure Matt and Dan will be able to touch on this, I really hope soon enough within healthcare it will be recognised as something that's psychologically traumatic, because I think from what Andrew and I have both said, it's a big point, it's a big factor.
Well, I'm currently on session 64 in regards to CBT treatment. So we're not talking sort of like a small amount. Here's 6 sessions on the NHS and that. I've done 64 sessions of private treatment, and I've just had the report now. And again, it's not going to be a quick fix. I'm probably going to be going through the same traumatic period over and over again for the next sort of 2, 3, if not 4 years, or if not life. And it's not just my impact, it's also the family impact as well. My wife has also been traumatized by it, because as far as she was concerned, I wasn't coming home. And from someone who was the main sort of bread earner for the family, and you've got a child as well involved, it's scary for them, and it's had a detrimental impact on the relationship as well. So yeah, but going by other interventions I've had, I mean, I've had cardiology, I've had respiratory, all by Guy's and St Thomas's, and East Kent hospitals as well. I've had multiple VQ scans, CT scans, MRI scans, Dopplers, but also it's the fact that I found it really surprising how trusts don't share information, where I've been having the same test done at East Kent as at Guy's and St Thomas's, which it's fundamentally a waste of money, because one hospital should be able to do that sort of examination and share it across the actual country. It doesn't matter where you live, then you can actually have treatment anywhere up and down the country, and your results are there essentially for people to see. But
I agree, Andrew. I've been under 4 trusts in total, and I've had the same scans done at all 4.
Yeah, and
because of image sharing.
Yeah, but then you go down the pain management route as well. It's like there is no sort of like the pain. I can't describe the pain itself other than it's like you're walking on Lego constantly, and you have that sort of like that sharp shooting feeling just going straight at the back of your calf into the knee, and it doesn't matter what pain medication you're on. I've had lidocaine infusions, lidocaine patches, bupropion patches. At one point I was taking 400 codeine tablets a month. 400. And you think, how did you get that? It's like, well, actually, it's quite easily when your GP doesn't monitor it. And they give you 3 months medication in one go, and then you're there. It's like, oh, okay, I'll just take one more. I'll take, oh, it's not working, I'll take a couple more. And before you know it, you've had like 30, 40 tablets in one day. And then you feel like, you wonder why you feel absolutely crap. And sorry, yeah, you feel rubbish. And then you actually look back at it and go, actually, I shouldn't be taking that many. And you reach out and instead of actually sorting the issue out, they give you more opioids. And I mean, pain management wise, I'm on Sevrodol, I'm on pregabalin. I've been on it for 3-4 years, and it's going to take a long time for me to get off opioids. And I don't know what the solution is for it, but I think pain management from a VTE point also needs to be looked at, because it's not just hematology, hemophilia. Yeah. And then respiratory wise, the impact of an actual PE, a submassive PE. I mean, I've got a third of my lungs which aren't actually working properly anymore. I know we don't use all our lung capacity, but the lung capacity which I have got is now reduced, and things like respiratory illnesses like COVID, you suffer more for it. It's hard, and the impact which it has is not just, oh, you're going to have a DVT and here's some anticoagulations. There is actually a whole massive team underneath it, going all the way from pain management to vascular. And I think when someone is in a situation like Hannah and myself, MDTs need to be more, they need to take place more often, and actually one person needs to take responsibility of that patient rather than multiple people having that input and then all going their own separate ways and having their own input anyway and having their own sort of like treatment pathways, and then it just doesn't marry up, and then you've got medication from one team which doesn't marry up with the medication from the other team, and then you've got conflicting medications as well.
Thank you. I'm sorry. No, it's excellent that we're getting this discussion going. So I think what I'd like to say to both of you is that I really appreciate you telling us about very personal stories, and we don't underestimate how distressing it is for you to have to recount that. And I think it will have been very valuable to all of us on the call. So we're very thankful to you for doing it. I'm just going to try and summarize some points from that. So I think this session is about recognizing VTE, but I think we're also hearing about the need for holistic and longer term care a lot in what's coming out in the discussion. There's one very brief point that's come through as a question, which I'm just going to take, and then we'll move on to the talks from the other panelists. So that question is, what impact has the experience had on your trust regarding any future care you might need from your GP? I just wondered, Andrew, if you wanted to briefly talk about that, and then we'll move on to the next part of the session, if that's okay.
Of course, no problem at all. My trust with my GP, Well, I wrote to my GP after my ordeal of being in hospital and saying, look, this is what's gone on. And the response was, thank you for your letter, Mr. Morris. Here, we've now removed you from our books and you've got 30 days to find a new GP. So it wasn't acknowledging that an error has been made by Park Surgery. It was actually, oh, thank you for your information. You need to find yourself a new GP because we don't like your complaint. So, yeah, trust. I haven't got trust in my GP. Do I trust hospitals as well? If I had to call an ambulance now, I wouldn't be asking them to take me to QE. I would be asking them to take me to GST in London, because they have restored my faith in the actual system. I don't think I would ever trust QEQM with my care again because of the impact that they had on me and the fact that they didn't listen, where I've had nothing but praise for guys in St Thomas's.
Can I just add on to that as well about trusting with GP? I moved practice voluntarily after my DVT. I didn't feel that my GP had listened, and they'd gone down the arthritis route, okay, based off my childhood, but they left it there. I really didn't feel that I saw two different GPs in that time period. Neither of them had thought VTE. I moved practice at that point. I chose to move practice. And I'm kind of now at a point where you ring to see a GP and they're not in on that day. You can see so-and-so, or you ring at 8 o'clock for an appointment and such is available, and it just so happens to be a GP I've not seen before. So you find yourself explaining your story over and over again to different people, which can also be really traumatic and not helpful in getting the care you need. I think that's just another point to add on.
I completely agree on that, Hannah, and also it all depends on who you see and what actual treatment they actually provide you as well. There's not sort of like a blanket sort of like, oh, this is how we're going to treat it. It's almost sometimes like trial and error. Oh, that didn't work. Okay, we'll try this instead. Which I understand everybody's completely different, and the fact that one medication might work for me, but it won't work for you, for instance. But at the same time, I think there's been a lot of, well, for me personally, I think there's been a lot of sort of like spin the wheel and see where we go.
Yeah, same for me. And it's very much like you say, GPs have different opinions on different things. And whilst we can understand the pressures on the NHS, it doesn't help with building trust. I think that's kind of the underlying point there, isn't it? Yeah,
absolutely. Yeah. I'm lucky I have got a very good GP now. Unfortunately, he is retiring, but he's brilliant and will sit there and listen and understand.
Thanks very much, both. I think the underpinning issue is having, as you've both said, people who you can come back to and who are responsible. We have very good relationships with primary care colleagues in Birmingham, and I think keeping channels of communication open, whichever specialty it's with, is really important. I quite often pick up the phone if I've seen someone in clinic to speak to the GP or other clinicians involved in their care, and I think we have to remember that it's sometimes easier for us to do that than it is for you to be phoning around and trying to access the teams that you need. So I'm going to move on to the next part of the session now and ask Matt to talk to us briefly about a primary care perspective about diagnosing and managing VTE. So thanks very much, Matt. Over to you.
Thank you very much, and thank you, Hannah and Andrew. I'm going to try not to be a specific GP here. I'm very used to speaking at events like this, and I'm not trying to justify the experience that you may have had with your GP. As a GP, we are the entry point for so much of the NHS, and so we are dealing with many things all the time. Now, years ago, I was taught by my trainer that one of the most important devices I could use as a GP was an egg timer. And the reason it was an egg timer is because people want to come and tell me their story. I have 600 seconds with a patient, And the easiest thing for any clinician to do is to interrupt. And what you find is that frustrates the person. They've got something they wish to tell you. And actually what most people will do will think you've not listened to the start of the story, so they'll just start again. And so actually teaching yourself that discipline of the fact that you should let somebody talk for at least 2 minutes. And if they choose to stop before that, that's fine. But allow them to tell the story. And in general practice, what you should be listening for is the person who's out of place. The Hannah, why are you in my consulting room? You're well, and now you're not. So the past behaviour needs to be considered in that consultation. Be wary of the unilateral symptoms. So why, if you've been out running, have you only got pain in one leg? What were you doing? Hopping? You know, why haven't you got symptoms that fit with my presumed diagnosis that you've pulled a muscle, you've overstrained yourself? If I'm talking about a leg, I have to be thinking, how is that leg connected to the rest of the body? So it is very, very easy for me, particularly if I've interrupted the story, that I might miss the comment about the fact that actually I'm a little bit out of puff now. Because if I don't think of VTE, if it doesn't cross my mind, I won't think to ask the next sequence of questions to say, could this be a VTE? And if it is a VTE event, could this now be moving from the leg to the lungs? And it's only listening to the story that I'm going to get that. But if I've never read a Harry Potter book, I will never think that the hero could be a guy called Harry Potter. So it's really important for GPs to think that VTE is out there, it's commoner than you think, it's going to have vague symptoms of presentation. And if I don't think about it in the first place, I'm going to miss it every single time. So actually being conscious of it is really important. Now, in the general public, in medical school, in hospital, heart attacks are drilled into our head as if they occur every day. Oh, they do. Pulmonary embolisms occur every day and they kill people like heart attacks. But why are we not taught about that? And I would argue one of the reasons for that is heart attacks are really quite easy. I hang around with a lot of cardiologists and I don't want to say you've got an easy job, but really, you've got an easy job. I mean, like, it tends to present in a classical way. You're sweaty, you've got this chest pain, the latest advert with the hands around the chest. It has quite standard symptoms. When we look at the symptoms of PE, shortness of breath, loads of my patients have shortness of breath, cough. I mean, during COVID, everybody had a cough. Yeah, and these aren't very specific symptoms. So the only way I'm going to find a VTE in the midst of all this is to have thought about the potential that this person could have had a VTE event in the first place. So number one for GPs is you need to put VTE in the same part of your brain as ischemic heart disease. Because if you don't have it there at your fingertips all the time, you're going to miss it. Beware of the unilateral symptom. Remember that actually swelling isn't the commonest feature of DVT. It's actually calf tenderness. So when you've got somebody who's out of place, presenting with leg symptoms just on one side, do a risk score. Calculate the Wells score in your head. It takes a moment. But because you've now done that pre-test probability, that risk that this could be a VTE, you then start to realise that this person is at risk of VTE events, and therefore I need to look. And then, of course, I'm going to examine the patient. And it's really important that if you're examining a leg, You're examining a chest. What is the single most important test I need to do in my clinical examination to see if somebody's had a pulmonary embolism? Listen to the chest, try and hear that pleuritic rub that, let's face it, most of us lied at medical school. We never really heard it. Is that what I should be doing? And yet again, in my career, no. The simple thing you do is take a pulse. Hence why I asked Andrew the question, because Andrew had the commonest presenting feature of a pulmonary embolism in a clinical examination. He had a sinus tachycardia. But that wasn't the cause. The beta blocker was inappropriate. What I should have thought is, why has this man got a sinus tachycardia? He's not panicking in front of me. He's not crying his eyes out. He's a police officer. Why is this sinus tachycardia here? VTE can be a sign of a pulmonary embolism. And because I've now thought about it, I can start doing the tests. What tests should I do? Well, to be honest with you, if you think that somebody's got a pulmonary embolism, my test is, let's see if my phone works, and get in touch with Daniel and ask him to give me some reassurance that this isn't the case. But if I wanted to do a test in general practice, what would that test be? Would it be an ECG? Because, of course, we're all taught about S1, Q3, T3, and I'm sure Andrew's ECG showed that at the hospital, because he was incredibly unwell. And that's when you're going to see those kind of changes. What would I see on an ECG? Probably a sinus tachycardia, most likely nothing at all. And that's if I'm competent enough to interpret that ECG. So that's not going to help me very much. A D-dimer might help, but I can't do a D-dimer when somebody's unwell and I'm going to send them away. Oh, by the way, I think you might have a life-threatening situation. Can you make an appointment with the nurse in a couple of days' time, get a D-dimer done? I'll speak to you in a week. Doesn't work. So if you're going to have a delay in getting that D-dimer, we're back to talking to our colleagues in the hospital and making sure we move people on to those people who can do the tests promptly, understand the result. So when you've got an elevated D-dimer and you can't explain why, start thinking why. Because it's not a test that you're going to expect to be elevated in a teenage girl for no reason whatsoever. So if you've done a test, interpret it. If you don't feel competent to interpret the result of a test, don't do the test. Send the person to somebody who's competent to be able to make that decision. Remember that in 40% of people who die of pulmonary embolism, they have seen their clinician within the previous few weeks with symptoms and signs they know are not right for them, and they have been missed. So we are talking about a significant risk of missing something. And then we hand over to Daniel, and I'm sure Daniel will take us through what AED and investigations need to be done. But I'm just going to return back to say, what should we be doing when I've had somebody come through the system and I get a letter back from the hospital and say, this is a VTE event? What should I do as a GP? I should do a significant case analysis of that. Was my practice involved in that patient's care? What did I do? What tests did I do? Did I listen to what they had to say? When somebody comes to my practice in the future with that kind of history, will I miss it again? And the only way you can stop yourself missing it again is to examine the case when it comes through. When I started in general practice in the 90s, we started to do significant reviews on all our heart attacks. And the reason we did that was to have the conversation with the GPs that using statins, controlling blood pressure, helping people stopping smoking, these were all really important. And if we didn't do it, people had heart attacks. And we did that really well. As I left general practice, and I too, Andrew, have retired, we were getting into the idea that we now need to do that on VTE. Why? Because we need to become more aware of VTE. We need to be aware of how vague the symptoms can be in presentation. make sure we think about the diagnosis and do some form of risk assessment, prove that this is not VTE. And so that way we can learn and improve our practice. A very brief anecdote. Patient came to see me, and it was that situation where, my God, she didn't really want to see me because I'm the heart guy, and she was convinced that her problem wasn't a heart issue, and she was talking about the fact she was a little bit out of puff. But she said one thing in her story to me, and that was at Robin Hood's Bay. If anybody's not been to Robin Hood's Bay, really well worth the trip. However, it's quite steep. And she talked about the fact that she went 6 months ago and she easily walked up the path, and now she couldn't do that. Something had changed. And actually, when you took her history, the most likely thing was that she'd thrown off a significant clot and now had significantly reduced stepwise respiratory function. Sent her off to the hospital, and I still get a very, very pleasant bottle of wine off her each Christmas because she regards me as saving her life. I think the hospital did a great deal of great importance. All I did was listen. That's all I did, and think, could this be a VTE? Thank you very much for your time.
Thank you. That was great, Matt, and some brilliant messages. I think listening is definitely the thing that we all need to do. And knowing that when someone tells you something's not right, that's normally the case, and trying to find out what it is. Just before we move on to Dan, I just wanted to make the point about the serious case reviews. So the audience probably all know as well that within hospital care, we have a system where we review patients who've developed hospital-associated DVT or PE, and we look back to details of the previous admission within 90 days of a diagnosis. That investigation is normally led by a consultant haematologist, and we look at what happened in previous admissions, and we identify learning points, and I'm responsible for that in parts of our trust, and we've made some great improvements in care by doing that. So I think that process, you know, is essential in all parts of medicine, to think about how can we listen to what we're hearing back about where things haven't gone as well as they should, and how we can change what we do in the future. It's all listening of different sorts, isn't it? So I'm going to hand over to Dan now to talk to us about emergency medicine and secondary care and his perspective. Thanks very much, Dan.
Thank you, Jill, and thanks to Hannah and Andrew for those very powerful stories, and thanks to Matt for the primary care perspective. I'm conscious we've got half an hour, and I want people on the group to get as much as they can out of this. So I think I'll be quite brief, and then I'll see what comes through on the chat, and I'm very happy to talk about any aspect that people would like to. I absolutely echo the messages so far that people need to think VTE, and one of the biggest challenges with this condition is that it can present atypically, and I'll talk a little bit more about that from a secondary care perspective. But just to put things in context, I suppose, I would say that we do a lot of investigations for VTE in secondary care. So my trust, for instance, we have a kind of ring-fenced ultrasound session, and we do between 6 to 8 slots every day, and we do weekends and occasionally bank holidays as well with that. And we have a suspected PE service that does somewhere between 2 to 3 CT pulmonary angiograms and VQ scans every day. And we do have good data on pre-test probability and post-test probability, and we know that when we scan for DVT, only about 1/5 of our patients has a positive result. So 80% of people that we evaluate don't have the condition. And in PE, it's even greater. So I suppose it's somewhere between 5 to 10% pretest probability. So we know that 90% of the times that we refer people for a scan of their lungs, they won't have a PE. So our consciousness of it in secondary care is already very high. We do lots of investigations that are negative because we're so terrified of missing it, and we're so terrified of missing the consequences that you very eloquently described in both those case studies. But we do still miss it, don't we? And so we have to ask ourselves, I suppose, where is that gap, and how can we improve it, and how can we reduce that gap? Because VTE is a different condition to myocardial infarction in that it is a blocked pipe again, but it's a blocked pipe that propagates, I think, as Matt mentioned previously, or Jill mentioned. And what we mean by propagation is we mean that the blockage at the pipe starts fairly low down in the pipe, and then as you don't treat it, the clot gets worse and it gets bigger and it gets higher. And the larger the clot gets, the more local destruction it causes, and the more likely it is to break off and travel around the body to the lungs or another site. So the consequences of delayed diagnosis are really quite extreme in VTE. Whereas if you have a heart attack, it's a relatively small pipe. If it gets blocked, you tend to present with typical symptoms. If you miss that, one pipe is blocked, but it's not going anywhere, and you're just left with the consequences of that single pipe, I suppose, rather than dissemination throughout the body. So we want to close the gap, and we want to make really prompt diagnoses. And I think, you know, one of the reasons that these sessions are so great is because we're really pushing the agenda about the fact that it's a hard condition to diagnose sometimes, and we really want people to think VTE. And I think there's a huge patient-facing role there, you know, and I think Thrombosis UK are doing a terrific job about disseminating awareness of this disease so that people can go to their GP, or they can come to secondary care and say, do you think it could be a VTE? Because once you've said that to me or to any practitioner, it's very hard for us to reassure you without doing tests. And we've got that message across, really. I think a lot of the gaps still exist because people just don't think VTE. So the patient won't be aware of it. The clinician will assign another diagnosis and then introduce some cognitive bias there, whereby they'll think, well, I already know what this is, so I don't need to think about anything else. But if the patients start to, at the very front door, say, do you think this could be a VTE? Then immediately, you know, you will set Matt off on a journey of, well, could it be? And if it could be, I should do some tests, I suppose, to make sure it's not. And firstly, that involves a clinical assessment, a history and an examination, just like Matt's describing. Then it involves sequential risk scoring. Then it involves blood testing, ECGs, secondary care evaluation. And some of that can take place in primary care. Some of it has to take place in a secondary care environment. But at least you've asked the question. And we've done lots of work over the last decade through the VTE Exemplar Network and through Thrombosis UK of saying that same message to clinicians. You know, could this be a VTE? You have to think, could this be a VTE? And I know Beverly Hunt, who's the medical director for Thrombosis UK, has done a lot of work about pushing the agenda of pain in isolation as a feature of deep vein thrombosis. So lots of clinicians will think, you're coming to see me with a leg that's sore, but it's not swollen. That can't be a DVT. You know, when a pipe is blocked and the blood can't drain, your leg will swell up, it will go red. You know, actually, that's not true. A lot of index presentations with deep vein thrombosis, people just have pain. And so we've been pushing that message, but I suppose I wanted to make the first point that message needs to be pushed from both angles. You know, we need to get patients asking, could this be a VTE? And we need to push onto clinicians, you know, you must think, could this be a VTE? The second thing I wanted to talk about, I suppose, is cognitive bias and the satisfaction of the search. So VTE can be an index diagnosis, but can also be a diagnosis in association with something else. So we know that having an infection or an inflammatory process increases your risk of VTE. And we know that being immobile in the context of another illness or an injury increases your risk of VTE. So just because you've hurt your leg and it's bruised and swollen doesn't mean you can't have a DVT as well as a fracture or as well as a muscle injury or as well as a local infection. And that's another thing that we've worked quite hard on in medical circles to try and demystify, to try and get rid of this illusion that, you know, once you've got an arthritis or once you've got a local skin infection, that must be the diagnosis and the reason for all of your symptoms. You couldn't possibly have anything else. Actually, you're more likely to have a DVT in the context of infection. So again, that's something that we're trying to push from a medical angle, but it's really important, I think, to push that from a patient angle as well. You know, yes, okay, you think this might be arthritis, but could it be VTE, or could it be VTE as well as arthritis? You know, shouldn't I have some tests to make sure it's not? And the earlier we ask these questions, you know, the earlier we pick up the diagnosis, the less the DVT propagates, and the less the consequences for everyone. Now the balance to that is that, you know, we could scan everyone for everything all of the time, and then secondary care would be completely congested, you know, and we'd really struggle. And so we do have to apply some common sense and some pragmatics to the diagnostic process of VTE. And Matt's already mentioned the D-dimer blood test and the Wells clinical prediction model, which is a kind of summary of the signs and symptoms, and I'd encourage everyone to look at that online. It's freely available on a number of calculators and apps, and it's very easy to Google the Wells score, and of course it's freely available in NICE guidance, which is open access and easily accessible, and I can put links on the chat if anyone's interested in that. But when we start thinking about VTE, then a clinical assessment and a D-dimer blood test will often get you over that initial suspicion. So a negative D-dimer has quite a good predictive value, really, at refuting the diagnosis of DVT. It only very rarely fails, and it only really fails in those people who have a very high clinical risk in terms of signs and symptoms. We know that it's overly positive, the D-dimer, so we would say it's non-specific, but what that means really is that there's lots of reasons it can be positive. So it doesn't just become positive when you have a DVT, it can become positive if you have additional trauma or infection. But what it's very good at doing is, again, getting you over the initial diagnostic hurdle of this can't possibly be a VTE, and getting you into the territory of, okay, now you definitely need a definitive investigation, be that an ultrasound or a CT scan or a VQ scan. So that's a very good way as well of getting people into the system for a further workup and trying to make the diagnosis as early as possible. And there is quite good points of care technology now for D-dimer assessment. So we covered that in the NICE guidance and have produced some recommendations on it. I know there have been some studies since that guidance as well. But as that becomes more and more ubiquitous in healthcare, then we can start saying, could this be VTE? And we can start doing finger prick D-dimer assessments in clinics. So that's one way that we're trying to improve the diagnostic process. The last way, I suppose, is just to talk about something that Hannah particularly mentioned with regard to ultrasound scanning, and something we've already talked about in the chat. So as an emergency physician, I would say that none of our diagnostic tests are gold standard in this kind of area. And what I mean by that is that the only way to really be 100% sure of the diagnosis of a deep vein thrombosis or a pulmonary embolism is to dissect down into your blood vessels and actually look at the clot that's right there. And of course we can't do that because it's invasive and it's painful and it has complications. So what we tend to do is something called reference standard tests, and they're tests that look for the presence of disease, and they're tests that give us an idea of what's happening in the vein itself. But those tests are not perfect. I think that's a point that I wanted to make in this talk, because Hannah's brought up a very good example of how, despite having tests that were negative and tests where someone attempted to reassure that deep vein thrombosis wasn't a possibility, actually, when she had slightly better tests or a delayed version of the test because she had ongoing symptoms, then the test was positive at a later date. And I think, again, it's really vital for patients to understand that and for clinicians to understand that the tests for VTE are not perfect. And that if you still have symptoms despite a negative test that are not getting better with treatment or rest or reassurance, then you need further investigations. And sometimes that is a repeat of the test you've already had, because when clots are very small, they're actually quite hard to detect via ultrasound. And when they're lower down the leg, they're hard to detect via ultrasound. But as they propagate and get bigger, they become easier to see. And I suppose that's one way in which VTE helps us, in that, as the symptoms, as the condition's not treated, the diagnostic tests become better and better and better because the clot's larger and it's easier to see and it's easier to diagnose. So a take-home message there for patients and for clinicians, if you're not getting better in spite of negative tests, you should still seek further input from health professionals. You should have further tests. And there are a raft of tests that can be done in VTE. So if ultrasound is not working for you, there are other options. Coming on to Andrew's story a little bit, PE is very difficult to diagnose. And so, again, I would really push the agenda of, can this be VTE for both a patient and a clinician perspective? We know that the commonest clinical presenting feature of pulmonary embolism is usually just shortness of breath. And people think of it as a constellation of signs, including chest pain, including dizziness and syncope, which is the medical term for a loss of consciousness. But it's very, very rare that patients present with all of those features together in the context of a VTE risk factor. You know, most people will tell us that they just don't feel right. And then it's up to the clinicians to try and elucidate some of that history around, well, what do you mean? Do you mean that you just can't walk as far as you usually can? Because that's shortness of breath on exercise. And that's a feature of pulmonary embolism, probably one of the commonest. Do you mean that you feel dizzy when you stand up or you exercise? Because that could be pre-syncope or that's syncope. That's a slightly commoner presenting feature in elderly patients or in patients who have a large volume pulmonary embolus. And the reason you have those kind of symptoms is because your venous return to the heart is obstructed. So when you ask your heart to work hard by exercise or climbing upstairs, you can't get enough blood back for the heart to do its job. And so you don't get a good blood supply to your brain and it starts to shut down and you pass out. But it takes a little bit of history taking and examination to put those things together in a healthcare context. And then, as Matt's already said, the commonest presenting clinical feature of a PE is the sinus tachycardia or a high pulse rate. And I think as clinicians, you know, we've tried to get that message out with research and with guidelines, but it's really important to get that message out to patients as well, so that, you know, when people like Andrew are told that they're having a panic attack, you know, they could hopefully in the future say, could this be a VTE? You know, isn't that a presenting feature of a blood clot, a high pulse rate? And I know it's unfair that you have to think about this, and, you know, doctors should do it all for you, but what we're trying to get across with some of these discussions and the good work Thrombosis UK is doing, that, you know, we're just trying to reduce the risk of these events happening again and again and again by empowering people to ask and to challenge and to think about VTE. Telephone consultations, you know, we can talk about that in the chat. You know, it's particularly risky for VTE, and I think if you're assured over the phone, then I think you should be challenging if things aren't getting better with rest and reassurance. And I'm sure Matt will have a perspective on that. Telephone conversations do a lot of good, you know, in terms of empowering GPs to talk to lots of people, but they have some real risks that needs mitigation in a modern health environment. Because when somebody comes into your surgery, or they see me in secondary care and they say, I don't feel right, and I ask them to undress for a physical examination, and I see that one of their legs is blue and swollen and painful to touch, I think VTE, you know, and I would never do that in a telephone consultation. And then I just wanted to touch finally on the psychological impact of diagnosis. So we've had really good case vignettes there, and we've had really good explanations of the downstream harm that late diagnosis can do, and the consequences of the disease. And I just wanted to make the point, as I've already done in the chat, that I don't think either of you are alone in this, Hannah or Andrew. You know, there is lots of work ongoing about the psychological consequences of a VTE diagnosis. I think some of those consequences stem from late diagnoses and a mistrust of the healthcare system, and I think we're starting to understand that more and more. Some of it stems from, you know, the consequences of a severe impact on physical health, and we know a lot about that from the intensive care environment. We've done lots of work with intensive care survivors around post-traumatic stress and the impact of a clinical admission to intensive care for any reason. And we know that people have nightmares. You know, we know that people wake up and you know, that they have delirium throughout their hospital stay, and they remember, you know, strange shadows on the walls, strange experiences, and they can't forget that despite reassurance in clinics and despite meeting those individuals again. And then we know that the physical limitations have psychological consequences, as we've already talked about, in terms of change of lifestyle and impact on family and loved ones. So putting all of that together, there's absolutely no, you know, there's no reason to think that there wouldn't be a psychological impact of diagnosis and disease, and we need to get better at managing that. And perhaps that's a good point for me to pipe down and hand over to Jill, who sees a lot more patients than I do in the longer term in terms of follow-up, and harnesses that multidisciplinary approach in terms of long-term symptoms.
Thanks very much. That's really helpful and interesting. We've not got long left, so I'm just going to talk very briefly about the kind of approach that I take when I see somebody in a thrombosis clinic, and the kind of things that I'm thinking about at that review, and then we'll take any last questions. So in my trust, we usually see people at 3 months after their thrombosis. And the reason for choosing that time point is because that's the time at which we would normally be deciding if people should have what we call limited duration anticoagulation because their DVT has had an obvious cause, or if we should be thinking about long-term anticoagulation. And the current NICE guidance is that a consultant should be part of that discussion about whether limited duration or long-term is needed. We don't not see people before 3 months, and our excellent anticoagulant specialist nurses normally do the reviews up to that point. But we do speak to them daily, and if they have patients who they're worried about before the 3 month time point, then we discuss them and we can see them before then. So I suppose what I'm thinking about when I see someone in that clinic appointment is that I want to give them a chance to talk to me, and I want to listen to them, as Matt said. I want to think about what impact the DVT or PE or other thrombosis has had on their life and on their overall care. And I want to produce a clear plan about what I'm recommending in terms of ongoing treatment and ongoing referrals. And we've talked about the need for pain clinic, vascular surgery, respiratory, sometimes obstetric input. So there's a huge amount of colleagues that I sometimes need to liaise with. And my aim for my colleagues is that they can look at my letter from that appointment and have a clear plan about what needs to happen going forward and who they can come back to if they've got further queries. So we've talked a bit about follow-up. We used a system of follow-up called patient-initiated follow-up a lot. That's quite a new concept, but actually I think we've been doing it for a long time, because my usual practice has been to sign off my clinic letters with, please come back to us if there are questions between appointments. Our contact details are listed at the top of this letter, and to make it clear that people don't need to wait until the next appointment to ask questions. So I think my role is almost like being a conductor, really. Somebody's thought about the diagnosis by the time I get to see someone. The reason the person is coming to me is because they've had it. And what I'm trying to do is to answer their questions, tie all the loose ends together and coordinate the ongoing care, and make sure that we've got a clear plan about what treatment is recommended and for how long. And before I stop, the final thing is that I would say that we in the past have had a lot of confusion where doctors will refer to long-term treatment. So we might say we'd recommend whatever medication, apixaban, long-term, and we sometimes get people contacting us back saying, what does long-term mean? How long is long-term? And normally what we mean by long-term is lifelong. So I try now to say lifelong rather than long-term, to make it absolutely clear that I'm saying this individual, provided there are no complications, should remain on this medication for the rest of their life because of the risk of having a further thrombosis. So that's our approach. We do have lots of demands on capacity, like all areas of the NHS, so we can't always follow everyone up as often as we would like to. But I think the main thing that I would want to do is to have appropriate safety netting so people know to come back to us if things change. And I would usually specifically say to them, we would want to know if you had a further thrombosis. We would want you to seek attention if you thought you were having one, and to make sure you get seen early. And we would also want to know if you got any other complications of being on anticoagulation. So especially in women of reproductive age, heavy periods often limit our ability to anticoagulate people, and that's something that we need to discuss. So that's the sort of gist of what we're doing, and then communicating back with relevant colleagues. So I'm going to stop there. We've got just over 5 minutes left. I can see there's quite a lot of comments in the chat, which I'll just read now. And if anyone does have any other questions or comments, we'd be very happy to take them in the last few minutes, or if there's anything else that any of the panel would like to say.
Oh, I'll briefly just say thank you now. Thank you to all the panel and everyone for listening. Yeah, thank you.
Thanks for your participation, Hannah. You've done the hard work.
I'd just like to thank Hannah and Andrew for their stories, and it's been an incredibly powerful session. But I'd just like to remind that this is not about the panel getting this right. This is not about Thrombosis UK getting this right. This is about all of us educating in our local health economies, health education systems, to make sure that VTE works its way up that clinical awareness, so that hopefully we will hear far fewer stories like Hannah and Andrew have given us today. But it's not just this panel and not just Thrombosis UK, it's you lot out there as well that needs to help.
Absolutely, and I can see that Dan's put some links to current guidance in the chat, specifically with reference to the need for early follow-up, which I think lots of people were saying is a really helpful thing to have. And obviously each trust will have their own way of structuring that. We have a system in our team where a consultant who's a specialist in thrombosis visits anti-coag clinic every day and talks through any new cases or concerns with the specialist nursing team there. And I find that a really helpful way of picking up any issues. We'll often contact patients as a result of those conversations ahead of formal appointments, and we would normally aim for the first appointment with a nurse specialist to be within a short number of weeks of diagnosis, because of the fact that we know people do have a lot of questions and need that opportunity to go through things. But nowhere is perfect. You know, every area and every part of the NHS has its own resourcing issues, and I think by talking about how much of a problem this is, hopefully we also help to get our teams appropriately staffed in the longer term, so that we can do all the things that are needed for patients with these conditions. Okay.
Sorry, Jill, can I just ask Dan a question? So Dan, from a point of view from my story, I had a blunt force impact and a provoked DVT, which then turned into a PE. From a natural emergency room point of view, would it not be of interest to actually prescribe anticoagulants to prevent an actual DVT occurring for a week, like they do, like the painkillers as normal? I'll take painkillers will prevent, or actual the ibuprofen to actually reduce swelling. Would it just not sort of like support and prevent?
Yeah. It's a very good question, and it's a specialist interest of mine. So thank you for asking. We know that there's an increased risk of VTE, but the absolute risk is relatively low. So it's somewhere between 2 to 3% of patients who go into a plaster cast or an immobilization device as a result of lower limb injury who'll suffer a VTE. So different countries practice quite differently. In Europe, so in France and Belgium, they used to give low molecular weight heparin injections to most people who went into a plaster cast or any form of immobilization, even if they were going home and being managed in the community. I think most people would probably argue that there isn't any evidence to suggest an injury with no immobilization should go in. But there is an ongoing research base. So we produced guidelines for the Royal College of Emergency Medicine on this in 2012. We've done some work with the NIHR, and we've produced some recommendations on that. And there is now a nice quality standard that if you injure your lower limb and you're being discharged, then you should have a risk assessment about VTE with your healthcare practitioner. And that's designed to, again, make everyone think VTE, you know. So not only is the clinician supposed to think, okay, I'm putting you in a plaster cast, I now need to do a risk assessment to quantify your risk of VTE, but that risk assessment is supposed to involve you as a patient so that you know that there is a risk of VTE over the next few weeks, so that if you do get odd symptoms in your leg, then, you know, you can start to ask more questions. You know, and I mean, it's all retrospective, isn't it? But one wonders if you'd been told about the risk of VTE of your leg at the point you injured it, you know, would you have had the same experience, or would you have been able to go back to your GP or secondary care with a leaflet saying, they told me I'd be at risk of VTE and now my leg really hurts, you know, don't I need more tests for this earlier? So we're working hard on that. The nice quality standard, I think, only came into effect last year. And then we're just applying for further research funding at the moment to look at the different risk scores that exist to guide risk assessment on this, and to look at DOAC medications versus low molecular weight heparin agents. So at the moment, all NICE recommends is that if as a clinician, I deem you to be particularly high risk of VTE, I should start heparin injections whilst you're immobile. And we know that patients don't like injections for 4-6 weeks. You know, it's a lot of pain and suffering, and they would much prefer tablets if we could prove that tablets were as effective. So that's our next research study that we're applying for funding for, in addition to raising awareness around this. But yeah, I mean, obviously there's still lots of work to do, as your case demonstrates.
No, absolutely. Thank you, Dan. I appreciate that.
I think with the risk assessments, it's often very practical things that make the implementation tricky. So we've had discussion with our ED team and plaster room about how we can get risk scores done and how we communicate that with the patient. And it's often very practical things that are the most challenging. You know, I think luckily everyone sort of recognises that this is something we need to think about, but it's about how we make sure it gets done on everyone, and how it's easy to do in a very busy clinical environment where there are lots of things going on. Okay, I'm going to wrap up there because we're 1 minute over. So I'd like to thank everyone who's joined us. It's been great to have lots of attendance and to have questions coming through. I'd like to thank Matt and Dan for their input on the panel and for their work in VTE overall. And it's great to have so many disciplines represented. But most of all, I'd like to thank Hannah and Andrew for sharing their stories with us, which has really been the crux of the session. So we'll close now, and I hope you all enjoy the rest of the meeting. Thanks very much.
Thank you very much.